Hypertension, high blood pressure, is a condition of persistently elevated arterial blood pressure and represents a complex interplay of multiple physiological systems. Its pathophysiology involves disruptions across neural, vascular, renal, and hormonal pathways. Chronic hypertension accelerates cardiovascular, renal, and cerebrovascular diseases, leading to significant morbidity and mortality. Below is an exhaustive, layered explanation of its mechanisms, beginning with the basics and moving into detailed systems. 1. Determinants of blood pressure. Blood pressure is the product of cardiac output and systemic vascular resistance. Cardiac output, the amount of blood ejected by the heart during each contraction. Cardiac output is determined by stroke volume and heart rate. Stroke volume is the amount of blood ejected by the heart during each contraction. And heart rate is the number of heartbeats per minute. Cardiac output is influenced by preload, venous return, afterload, resistance to ejection, and myocardial contractility. Moving towards the second determinants of blood pressure. Systemic vascular resistance, determined by arteriolar tone, which is modulated by neural, hormonal, and local factors. Resistance to blood flow primarily occurs in small arteries and arterioles. It is influenced by vessel diameter. Smaller vessels increase resistance. Blood viscosity. Thicker blood, e.g. due to high hematocrit, increases resistance. Vessel elasticity. Stiff or hardened arteries, e.g. in atherosclerosis, elevate resistance. Hypertension occurs when there is sustained elevation in cardiac output, systemic vascular resistance, or both. 2. Neural regulation. Sympathetic nervous system. The sympathetic nervous system plays a pivotal role in acute and chronic regulation of BP through adrenergic receptors. Alpha-1 adrenergic receptors mediate vasoconstriction in vascular smooth muscle, increasing systemic vascular resistance. Beta-1 adrenergic receptors, found in the heart and kidneys, increase heart rate, myocardial contractility, and renin secretion. Beta-2 adrenergic receptors induce vasodilation in some vascular beds, but are overpowered by alpha-1 effects in hypertension. Mechanisms of sympathetic nervous system dysfunction in hypertension. 1. Increased sympathetic nervous system activity. Persistent sympathetic nervous system activation drives vasoconstriction via alpha-1 adrenergic receptors, increasing systemic vascular resistance. Beta-1 adrenergic receptor stimulation in the heart enhances heart rate and myocardial contractility, increasing cardiac output. Increased baseline vascular tone. Hypertrophy of vascular smooth muscle. Stimulates renin release, activating the renin-angiotensin-aldosterone system, RAAS. 2. Central nervous system dysregulation. Hypothalamic centers, e.g. paraventricular nucleus, and brainstem nuclei exhibit heightened activity. Stress and obesity exacerbate central sympathetic nervous system drive. Baroreceptor. Located in the carotid sinus and aortic arch, baroreceptors respond to changes in arterial wall stretch. 3. Baroreceptor reflex dysfunction. Chronic exposure to elevated BP desensitizes baroreceptors in the carotid sinus and aortic arch. This resetting leads to a higher set point, allowing persistent hypertension without adequate sympathetic nervous system inhibition. 4. Neurotransmitter imbalance. Excess norepinephrine and reduced inhibitory neurotransmitters, e.g. gamma-aminobutyric acid GABA, contribute to elevated sympathetic nervous system output. 3. The renin-angiotensin-aldosterone system, RAAS. RAAS is a major endocrine system controlling BP and fluid balance. Dysregulation of this system is central to the development and maintenance of hypertension. A. Normal RAAS physiology. 1. Renin secretion, secreted by the kidney. Triggered by decreased renal perfusion pressure, sympathetic nervous system activation, or low sodium delivery to the macula densa. Renin converts angiotensinogen produced by the liver into angiotensin 1. 2. Angiotensin 2. Angiotensin-converting enzyme, ACE, converts angiotensin 1 into angiotensin 2. Potent vasoconstrictor, directly increasing systemic vascular resistance. Angiotensin 2 stimulates aldosterone secretion from the adrenal cortex, enhancing sodium and water reabsorption. Angiotensin II promotes cardiac and vascular remodeling via hypertrophy and fibrosis. 3. Aldosterone. Angiotensin II binds to receptors on the adrenal cortex, prompting aldosterone synthesis and secretion. Aldosterone acts on mineralocorticoid receptors in the distal nephron. Aldosterone increases sodium reabsorption and potassium excretion, expanding extracellular fluid, ECF, volume raising cardiac output. B's RAS overactivation in hypertension. Elevated renin levels. Increased renin activity amplifies the production of angiotensin II and aldosterone. Angiotensin II effects include direct vasoconstriction and heightened vascular resistance, enhanced sympathetic nervous system activity via central and peripheral mechanisms, stimulation of pro-inflammatory and pro-fibrotic pathways in vascular smooth muscle and the myocardium. Aldosterone-mediated sodium retention sustains volume expansion, perpetuating hypertension, and contributes to vascular stiffness and endothelial dysfunction. 4. Vascular dysfunction. The vascular system contributes to hypertension via structural and functional abnormalities. A. Endothelial dysfunction. Normal role of the endothelium. Produces vasodilators such as nitric oxide and prostacyclin. Nitric oxide promotes smooth muscle relaxation and inhibits platelet aggregation. Prostacyclin prevents platelet aggregation and constriction. Produces vasoconstrictors. Endothelin 1 and thromboxane potent vasoconstrictor upregulated in hypertension. Pathological changes. Reduced nitric oxide bioavailability due to oxidative stress or reduced endothelial nitric oxide synthase activity. Endothelin 1 levels rise in response to hypertension-associated stressors like high sodium levels and promotes vasoconstriction and increased resistance. Pro-inflammatory states impair endothelial repair and function. Cytokines, e.g. IL-6, TNF-alpha, increase endothelial activation, promoting leukocyte adhesion and vascular injury. B. Vascular remodeling. Chronic hypertension induces structural changes. Hypertrophy of vascular smooth muscle. Thickening of the arterial wall to withstand higher pressure. Extracellular matrix accumulation. Increased collagen and fibronectin deposition stiffen vessels reduces elasticity and compliance. Lumen narrowing. Smooth muscle cell proliferation narrows the arterial lumen, contributes to increased systemic vascular resistance. C's arterial stiffness. Progressive loss of elastin and increased collagen deposition stiffens arteries, particularly in aging and chronic hypertension. Stiff arteries transmit pressure waves more rapidly, increasing systolic BP and pulse pressure. 5. Renal contributions. The kidney regulates BP through sodium balance and long-term volume control. A. Sodium handling. Impaired pressure natriuresis. Normally, elevated BP increases sodium excretion. In hypertension, the pressure natriuresis curve shifts rightward, requiring higher BP to excrete sodium. Sodium retention. Excess sodium retention expands extracellular fluid volume, increasing preload and cardiac output. Mechanisms include RAS overactivity, impaired renal function, and altered sodium transporters. B. Nephron number hypothesis. Reduced nephron numbers, due to genetic or developmental factors, decrease the kidney's ability to handle sodium, leading to hypertension. C. Glomerular ischemia. Chronic hypertension causes glomerular hyperfiltration and ischemic injury, perpetuating renal dysfunction. Chronic hypertension causes afferent arteriole thickening, reducing renal perfusion and glomerular filtration. Nephron loss exacerbates sodium retention and BP elevation. 6. Hormonal, metabolic, and inflammatory factors. A. Vasopressin, antidiuretic hormone. Promotes water reabsorption via aquaporin channels in the renal collecting duct. Increases intravascular volume and BP. B. Obesity and insulin resistance. Leptin. Activates sympathetic nervous system and impairs renal sodium excretion. Insulin resistance. Enhances sodium retention, vascular smooth muscle proliferation, and angiotensin II effects. C's chronic inflammation. Pro-inflammatory cytokines, IL-6, TNF-alpha, amplify endothelial dysfunction, vascular stiffening, and RAS activity. 7. Oxidative stress and chronic inflammation. A. Reactive oxygen species. Sources of ROS include NADPH oxidase, mitochondria, xanthine oxidase. Effects of ROS. Inactivate nitric oxide, increase vasoconstriction, and promote remodeling. B. Chronic inflammation. Inflammatory cells infiltrate vascular walls, releasing cytokines that amplify RAS and sympathetic nervous system activity, perpetuating hypertension. 8. Genetic and epigenetic factors. A. Genetic contributions. Polymorphisms in genes regulating RAS, sodium transport, or vascular tone predisposed to hypertension. Single gene mutations, e.g. Little syndrome, glucocorticoid-remediable aldosteronism, can cause rare monogenic forms. B. Epigenetic changes. Environmental factors, diet, stress, may alter gene expression, increasing susceptibility to hypertension. 9. Target organ damage, TOD. Chronic hypertension damages multiple organs via pressure overload and vascular injury. A. Heart. Left ventricular hypertrophy, LVH, increased afterload causes myocardial thickening, leading to diastolic dysfunction. Heart failure. Progression to diastolic or systolic dysfunction. Coronary artery disease. Accelerated due to endothelial dysfunction and atherosclerosis. B. Brain. Stroke. Ischemic or hemorrhagic events due to vessel rupture or occlusion. Vascular dementia. Chronic small vessel disease leads to cognitive impairment. C. Kidneys. Hypertensive nephropathy. Glomerular ischemia progresses to chronic kidney disease, CKD. Proteinuria. Early marker of renal damage. D. Retina. Hypertensive retinopathy. Arterial narrowing, hemorrhages, and papilledema indicate severe BP elevation. E. Peripheral vasculature. Aneurysms, caused by weakened vessel walls. Peripheral arterial disease impaired blood flow to extremities. Conclusion. Hypertension results from multifactorial disturbances in vascular, renal, neural, and hormonal systems. These processes increase systemic vascular resistance, alter sodium handling, and elevate cardiac output, creating a vicious cycle of sustained high BP. Over time, this damages organs, leading to cardiovascular, renal, and neurologic complications. Early diagnosis and targeted treatment are crucial to interrupt these mechanisms and prevent severe outcomes. Thanks for watching Doc AT.